I'm now delighted to introduce our keynote speaker, Mr. Aneesh Chopra. Mr. Chopra served as the first Chief Technology Officer of the United States, reporting directly to President Obama. Amassing what the White House called, quote, a dizzying array of accomplishments, Mr. Chopra's contributions included the National Wireless Initiative, which is a set of Internet policy principles that informed the White House's response to proposed online piracy legislation. He also pioneered a number of initiatives related to the administration's open government strategy, including the data.gov platform. Mr. Chopra previously served as Virginia's Secretary of Technology and as a cabinet member of the Council on Virginia's Future, where he launched the Productivity Investment Fund to spark innovation in state government. Virginia's productivity and transparency measurement system was cited by Governing Magazine when it named Virginia the best managed state in 2008. Please join me in welcoming our distinguished guest, Mr. Aneesh Chopra, who will address a topic very much on the minds of our member boards and the Federation, and a great topic as we enter our second century of service, the future of technology and healthcare. Welcome, Aneesh.
Cheers. Good morning. It is indeed an honor to be with you on this auspicious occasion. One might think about the centennial and imagine a world of coasting into the second century. But that is not the story of the FSMB. It is now that your needs, your role is in the ascent. When Dr. Benjamin and I served together in the administration, we spoke often of that this moment in American history, it is the absolute best time to be a healthcare innovator. But where innovation thrives, the importance of protecting the nation's health, welfare, and safety is all the more important. So with your indulgence, I'd love to share with you a few words about the three megatrends that are taking hold in the nation's healthcare system and the implications for those of you gathering on this very special occasion. But I begin with a bit of a sobering message about the nation's healthcare economy. You see, we are in a challenging state financially. America today is looking to put the healthcare system on a proverbial budget. That challenge is best exemplified by the graphic you see before you, suggesting that the rate of healthcare inflation has been and continues to be projected exceeding the rate of overall inflation in the American economy. It's had an impact on our nation's budget, as you hear the debate in Washington. It's had an effect on our nation's employers, who fund a great deal of the private insurance market. And increasingly, it's having an effect on our individual consumer budgets. As a result of these three macro forces, the country is asking the question, how might we achieve the quality of care that has been symbolic of our nation's care delivery system, but at a rate of cost that is affordable and achievable within the constraints? This is the movement, the shift, if you will, towards a value or accountable-based care delivery system that promises over a decade, at least, of fundamental and transformational change in the way we practice medicine, the way our patients engage the healthcare delivery system, and dare I say, the way we pay for that care. The challenge for us is to think about this ecosystem of hospitals and doctors, payers and employers, and right there in the middle, our patients protected by you, who are trying to understand in this environment where the accountability shall sit. And it is in this environment, powered by the changes of technology and data and innovation, that the ascent I spoke of about your role in the nation's healthcare system is all the more important. The lines between payer and provider, doctor, employer, and patient are all blurring. What are these megatrends that are facilitating this movement and begging us to have this question today? Our argument in brief is simple. The combination of the opening up of healthcare information, what my colleague, now my successor, Todd Park, the Chief Technology Officer of the United States, part two, is the information liberation movement as our first megatrend. Second megatrend is the shift to incentives to digitize the nation's healthcare system. And third megatrend is the incentive change in how we pay for care. The combination of these three forces, we believe, will act as rocket fuel for breakthroughs in care delivery that will affect neighborhood by neighborhood the practice of medicine. I'd like to spend a few moments providing the context for these three trends before I provide for you the challenges and opportunities that confront the community of state medical boards. I am particularly fond of our first trend, the opening up of healthcare data, because this is something the President had called for literally on his first day in office. Amidst the economic crisis, amidst all of the turmoil, the change, the President sat to write a directive. Actually gave me my first homework assignment, Dr. Chowdhury. He said, I would like recommendations on how the government can be more open, defined to be more transparent in its performance, more participatory in how it sets rules, and more collaborative in the execution of policy. It is in our healthcare community we've seen the most mature adoption of the President's philosophy. You see, we as taxpayers have spent billions of dollars collecting information about the nation's healthcare system. But for the most part, that information, Dr. Benjamin, had been stored in file cabinets in Washington, D.C. Today's technology allows us, dare I say, requires us to open up this treasure trove, this asset base that could serve as the active ingredients of breakthrough ideas that we have yet to even imagine. I'll share but two stories, examples of what the liberation of data has meant for neighborhoods in communities all across the country. First is the story of a little startup called iTriage, based in Boulder, Colorado. iTriage had a very simple proposition. We all carry our smartphones today, and might we use the capability of the smartphone, our location, and other information to connect to the internet so that we might, if we have a loved one or ourselves feel the need to seek care, to have a form of non-medically not regulated, I should say, a triage function. Where should we seek the care? Should we visit the emergency room? Is there a care clinic nearby? Where might we seek the care if we feel it's that time for us? And iTriage had a very simple proposition that customers loved. They just used it to navigate our very complicated healthcare system. About 2 years ago, Dr. Hudson, the president and CEO of the company, had visited us at the White House and asked about how we might collaborate. And we said, look, we've opened up all of this data. Perhaps you might put it to use. Dr. Hudson found the database of every free or reduced healthcare clinic in America, our FQHCs. And he decided to load all of that data into the system. So not only could one triage based on setting of care, but could make a judgment about cost, depending on their circumstances. He didn't know what might come of it, and he thought it'd be an experiment. In 1 year, his cute little app generated 76,000 referrals to free or reduced cost clinics. Instead of requiring the American people to go dig and find the information for where they could seek care, it's now presented to them in tools like Dr. Hudson's iTriage. By the way, how much did Dr. Hudson pay for that database, Dr. Benjamin? Zero! That's right. It's the American taxpayer that's paid for it. It's yours to use. In the similar spirit, Asmopolis, Dr. David Von Sickle, a former CDC researcher, raised a very bold proposition. Is asthma preventable through information? Pretty bold concept. He went and asked the following question. Do we have the technical capacity to locate where and when a person suffers an asthma attack? Well, people depress their inhalers. For a marginal cost of $15, he developed a little chip that sits on top of the inhaler. You see it pictured on the graph. And when the patient depresses the inhaler, it records the location and the time. Dr. Von Sickle gathers that data individually and as a community and maps it or plots it on call it Google Maps. and presents the information back to the patient. In his small trial run, by the way, he's a startup, he's a CEO of a startup, lives in rural Wisconsin, does not have access to broadband, travels 45 minutes to Madison to get to work every day. He found a 50% reduction in the most extreme form of asthma attacks because information empowered the patient to know where to avoid, basically, in their travels, that which had caused them the attack in the first place. These startups, iTriage, Asmopolis, are actually for-profit businesses. They're what we believe will be the next wave of the billion-dollar market opportunity. You hear a lot about Groupon and Apple and Facebook, IPO. The next exciting wave of capital success stories in the American economy will be those technologies and services that incorporate open data, take advantage of the other two trends, and provide for the American people a very compelling service that will improve quality and lower costs. We will be, FSMB folks, inventing our way to a better care delivery system. And in both examples, they've attracted venture capital, and in the case of iTriage, they've already been acquired. This is the beginning of a movement, opening up data at the macro level on statistics, on obesity rates, and other prevention indicators. As Dr. Benjamin spoke about the Prevention Council, there's a data set that follows the National Health Indicators Warehouse, as well as patient individual data. You see on the graph a description of the word blue button, a challenge the president made in August of 2010 to every veteran in the nation, that by 90 days after the speech, he had challenged his Veterans Affairs Department to provide every veteran the ability to download their personal health care data with a simple click of a blue button. That service went live, as expected, in October 7th of 2010. And by today, Dr. Chowdhury, 800,000 veterans have downloaded a copy of their personal health data for their own comfort and use, and increasingly to share with other providers or third-party service providers or applications that will help them stay healthy. So this is trend number one, the opening up of data. Trend number two is the incentives. Incentives to spark the adoption of digital health infrastructure. Now, this graphic blows my mind because while we celebrate the centennial, we know that the healthcare industry isn't exactly internet-paced growth for change. It's generational change that has traditionally marked healthcare. Yet look at the graphic. In 1 year, we have doubled the number of providers that are using electronic health records. And this is not survey data. This is actual utilization on the SureScripts e-prescribing network. We are now over 40% adoption, and that number is clearly passing through to 50% in pace through the President's investments in the Meaningful Use program to achieve widespread adoption over the next 5 years. What is amazing about this movement is it's not just about technology as noun. You know, when we are often invited to talk about technology, the question is, can you talk about the iPad, and can you talk about my cell phone and all the tools that are out there? It's really exciting. It's not the noun that inspires us. It's the verb. It is the use of the technology to empower patients, to empower providers, frankly, with the information they need to make better judgments about the care they wish to deliver to their patients. And to demonstrate the impact, no better than the Cleveland Clinic's own survey of the community results, a 25,000 patient survey in the Cleveland area evaluating how we care for patients who are diabetic, and to segment the results based on whether or not the provider was using an electronic health record or paper records. And the data was unbelievably stark. Now, I went to Johns Hopkins, so most of my classmates are in medical school, so many of them are regulated by you. I can assure you that every medical student knows the basics of how you care for someone who's diabetic. You measure their hemoglobin A1Cs, you manage their kidneys, you check their eyes and their feet. Pretty basic stuff. The things you do to a patient that's diabetic. But in this study, only 7% only 7% of the patients treated by those doctors in paper-based environments received all of those recommended care processes. Now, the practices that were supported by electronic medical records weren't all that great either, but at 51% they were dramatically better. Now, you might argue, is it the processes that matter? Maybe I don't have to check the eyes, maybe not the feet. How about the outcomes? Were the results different? Were their LDL levels under control? Did they stop smoking? What about their hemoglobin A1C? What about their blood pressure? Well, again, a stark contrast on the data. For those patients in clinics with paper-based records, only 16% achieved the outcome standards 4 out of 5 times. Not perfect, but significantly better were those in the electronic health records practices, achieving the outcomes we desire 44% of the time. Now, you might wonder, 4 out of 5, what's the one thing we can't change? Dr. Benjamin, what's the one thing that is really impossible to change regardless of whether you're at a paper-based or an electronic system? That's right, our body mass index. It's hard for us to lose weight. The second sea change that is affecting our industry is the way we pay for care. Now, I'm a technologist, not an economist, but if you understand economic forces, we respond to incentives. And in today's fee-for-service environment, whether we like it or not, the incentives are to do more. See that extra patient, not in 6 minutes, but 5.5 minutes. And next year it'll be another patient at 4 minutes and 35 seconds. And on that pace we go. Most of my friends in medicine say, when will this wheel stop spinning? Ever more patients, ever less time, ever more burdens, ever more documentation requirements. How much more productivity can I achieve just to get by, to pay my loans, to make a living? These are the incentives. Are these the right incentives? Wouldn't we prefer those providers who understand the challenges and the opportunities to care for their own patients to focus on their outcomes and their results by any means necessary? The President said in the State of the Union, one of the wireless initiative examples, that he sees a future where physicians FaceTime video chat their patients. Well, how does that work today? Today you do a FaceTime video chat, not reimbursable. You meet them in person, reimbursable. So now we are moving to the payment model of paying for outcomes or value. And in the Affordable Care Act, there is an incredibly powerful provision, the most powerful provision of all. The provision that says we are effectively, in my words, depoliticizing how we pay for care. For the most part, you got to schlep up to Washington and knock on your congressman's door and say, please, 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 don't cut my reimbursement 80 bajillion% because, you know, we're suffering the other round of SGR. Now, the Centers for Medicare and Medicaid Innovation has the legal authority to test, validate, and scale any payment model that focuses on outcomes if the actuary of HHS can certify that the patients achieve better quality and lower cost. Did you all know that? No. This is the least understood provision of the Affordable Care Act, but it's the most important factors and regulators to ensure that they behave appropriately under these new incentives. That's why you're in the assent, Dr. Ryan. So, what are some of these provisions? Well, you know some of them because they're top-down. Do you want a patient-centered medical home? Will you be an ACO? Will you participate in bundled payment programs? Will you basically change your practice patterns to reduce the risk of unexpected readmission rates? But those are not the main event. That's sort of the appetizer, the stuff that Congress wrote about in the law. It is the opportunity to try breakthrough new ideas that will have completely different risk-sharing agreements and different workforce implications. That's where I will get to in a moment when I summarize the implications for you. But I am a technologist, so I'll share just briefly the kinds of technologies that will be unlocked from our nation's economy given this change in pay. You're going to see an investment in data mining. So if you ever type in a Google search and it finishes the sentence for you, imagine a physician's schedule similarly filling out on its own. Don't wait for the patient to call you. Figure out which of your 2,000 patients you need to call. The software will help you mine for the most likely patients to suffer a concern and will alert you to what you can do to do something about it. Care integration tools, decision support tools, technologies that allow you to communicate directly to your patients in new and creative ways. These are the market opportunities. Why the next billion-dollar industry will be in enabling this shift to value-based care. The underlying challenge for this community in addressing the regulatory pressures of the next century are to figure out where to assign accountability and to manage and assure the public's health, welfare, and safety in a world where shift and risk are moving up and down this continuum. So I'll share 3 very simple lessons for the state medical boards, borrowing a page from our work in the internet economy. It is my humble opinion that what has made the American story of democracy its best has been this bottom-up theory of change, the importance of our federalist system, where states and localities address the unique challenges that confront them. Yes, we have opportunities to standardize and harmonize at the national level, but the choices and the judgments to address these changes in risk will come and must come from you. In the internet economy, we've seen this in a global context. Cloud computing, internet privacy, even online piracy, people downloading illegal movies. This is a conversation that requires us to think anew about boundaries. There will not be one mega country that will tell the world how to regulate the internet. Nor will there be one mega regulatory framework to tell every one of you medical boards how to practice the work that is so critical for you. We had an example of this in energy. I serve as the President's technology advisor, so health and energy and education are all the same. When the White House issued its report on modernizing the electric grid, we faced a similar analogy to healthcare. States control the regulatory tools for safety and welfare, and the feds have a conversation about technology. And in the combination, we said very clearly, states are in control of the judgments as to whether or not we modernize the electrical grid. However, we will collaborate in technical standards and in the sharing of best practices so we don't have to reinvent the wheel in every single state. This is about empowering you so that you can make the best decisions for your community so that your mission can be achieved. To give you a simple example of collaboration versus top-down forcing, I share with you the story of safe, secure email. You see, as healthcare information moves on the internet, we had a challenge. How many of you email sensitive patient health data across the internet using your Gmail account or Yahoo? Please don't raise your hand, because I'm sure a regulator in the room is going to say ixnay on the email. So you don't do that because it's not really safe or secure. But that doesn't mean we can't solve this problem, because we want people to communicate. So, in 90 days, we convened stakeholders from the private, public, academic, nonprofit sectors. We locked them in a virtual room, and we said, just come up with technical standards for safe, secure email. We're not inventing a new form of physics. We've done this in other communications, so can we just apply it to healthcare? And sure enough, in 90 days, a battle royale commenced and the winning model emerged. We're going to authenticate the sender and the receiver and encrypt the message in between. Without mandating it, forcing it, subsidizing it, we just put together a collaborative, we call this, the role of government as impatient convener. And we convened. And today, every physician in the country has the technical capacity to get a safe, secure email account. The going price is $15 a month in the private sector, and I promise you that price will fall. We need to spark an innovation economy, apps for quality and safety that will extend the value of that digital health infrastructure. I share with you the story of Dr. Gunston Ho, who is an example of this movement. He's a primary care doctor in San Francisco in Chinatown. Small practice. Used to be fee-for-service. Now he gets paid 180% of Medicaid fee schedules in order to provide care coordination tools. The problem is his digital EHR didn't really have the capability you need if you're supposed to coordinate care across settings. He didn't have a Google-like search engine to figure out who was where and what as his patients were navigating different places for care delivery. So, because of the internet economy, we are opening up these software platforms, encouraging more of them to interoperate. Dr. Ho was able to buy a third-party tool called Apixio that gave him exactly what you see on the graph, a Google-like search interface so he could find information about his patients to do his job in a new environment. You're going to see new applications developed to protect patient safety, to improve quality. And it is this emerging apps economy that is why we are so excited, one of the reasons why we are so excited about the change in the nation's healthcare system. For you, it is a bit more complicated. Who will be providing care? We have authorities on the role of nurses and physicians, and there's a debate about physician extenders and a whole range of other individuals. It is exactly what's coming out of the president's billion-dollar health innovation challenge run by that Medicare Innovation Center I referenced earlier. We put out an open call. What are the ideas that you have to change the way you get paid as a doctor and the staffing you need to provide the support so that you can care for patients in this accountable care world? Well, look at the demand. We put out this call and gave 30 or 45 days, I think it was, for response, Dr. Benjamin. 8,000 people in every corner of the country. You could see the intensity of the applications by color code in the graph applied. Soon, the Medicare Innovation Center will report which of the subset of those 8,000 will be pilot projects they will evaluate. But every single one of them was required to describe the new workforce capability that they envision needing in order to support patients in this value-driven world. It is incumbent on FSMBs to think, the state medical boards, forgive me, and the Federation more generally, to think about the workforce in this new value-based world. All the more pressure on the community for you. By the way, the civic volunteers, many of you physicians do this. I know you get paid some per diem for many states, but it's a pittance on your salary. You're heroes for volunteering to do this. This is where your brain power will be best put to use as we move the needle on where and how care will be delivered. An example of one of the examples of this debate has been the shift in the thinking around what telemedicine is. You know, traditionally, you've been a leader on telemedicine for decades. You've been thinking about this, discussing this, debating it, model policies, guidance, suggestions. But that was a traditional world where you were distant. The patient and the doctor didn't have a relationship. They were distant, but they were connected by some video chat. But what about the integration? You are my patient. I have a relationship with you. But I want to FaceTime video chat you for 30 minutes or 30 seconds because there's a burning question. I can answer it on the fly. That's a different form of telemedicine. And I give you an example of a startup that is integrating this in the provider's electronic health record. Don't just talk about the medical record and the encounter physically in the room. Think about this in the context of 24/7 collaboration, the relationships now that are emerging between providers and their patients. But I'll end with this final observation, briefly, to tell you the story of a young man named Tony Webster, who inadvertently became a hero for our nation's veterans, to describe the pace of change in this environment. The president issued a challenge to the private sector in August, asking for them to hire 100,000 veterans by the end of next year as they return from Iraq and Afghanistan. And the challenge was, the opportunity, I should say, because it was exciting, most employers said, yes, sir. We have well over 100,000 jobs pledged by employers already, months after he announced the challenge. The question was, how will a veteran find a job opportunity? You know, in the old days, the government would have created some big government database, www.findyourveteransjobs.gov. It would have been over budget. We wouldn't have had it built for 3 years. It would have failed. It would have been a miserable experience for the patient, for the veteran. That was yesterday. Today's a new day. And in today's technology and innovation economy, the answer lies with a young man named Tony Webster who built the following in 30 minutes at no cost to anybody. It asks your military occupation code. What's your resume when you left the military? It asks your zip code. Where do you live? And it asks for your cell phone number. And every morning, it text messages you 5 of the most relevant jobs that are available for you in your community based on your unique skills that you've acquired in the military. He built that in 30 minutes. Why? I was in San Francisco on a Tuesday at 4 o'clock, and I was just happy because Dr. Jill Biden was going to join me in San Francisco the next day. So I just thought to say it. Hey, folks, I'm going to be with Dr. Biden to celebrate folks building apps for heroes. And the CEO of a company called Twilio said, hey, can I get an invitation? I said, well, you have to have built an application that can help veterans find jobs, and it's just 24 hours away. I'm not so sure you can do that. He goes, no, I can do that. I said, well, then I got Secret Service. That's a headache. Dr. Benjamin knows. I got to clear the name. I got to get them approved. It's okay. When can you? How much time do you need for that? I said, and I'm thinking on the fly. If you make the application by 8 o'clock in the morning, I'll do my best to get them through Secret Service. So the CEO of the company sends out a message. We had opened up a whole bunch of this data. That's a 20-minute story, but we've opened up this Veterans Job Bank on jobs that are available and a whole bunch of other things using the internet. And we opened up all of these data sources. And he sent a message, flash challenge. Anyone who works, he's got 75,000 software developers that work in his ecosystem. Anybody that builds an app by 8 o'clock in the morning and meets the test, you can go visit Dr. Biden. Tony Webster got that message and got to work and finished his job in 30 minutes. It was harder for me to get Tony in through Secret Service than it was for him to launch HeroJobs.org, a platform that will help our veterans find those jobs from those employers who've pledged. This is the innovation economy we're living in, measured in minutes, hours, days, not years or decades. This is why it's an amazing time to be a health innovator and why we need you more than ever to protect the nation's health, welfare, and safety. God bless you and your mission, and thank you for your time.